Hello, good afternoon. Thank you for coming to my presentation today. I'm going to talk to you about how we estimate what patients pay to manage major depression. I'm presenting on behalf of some of the study team members for the pharmacogenomics in depression study. It's a smaller piece focused specifically on the cost that patients pay. My name's Sonia Cressman. I'm a health economist and I work at the Center for Clinical Epidemiology and Evaluation. Before I begin this talk, I'd like to acknowledge the unceded land of the Musqueam, Squamish, and Tsleil-Waututh First Nations where I am currently working. Here in Vancouver, there's a beautiful sunset just as we finish winter. Now, financial protection is the goal of universal health care coverage. Financial hardship is defined when 10% of household income is spent on healthcare costs. And depression is a really major financial burden worldwide. It's estimated that in the next 10 years, depression will become the world's leading cause of disability. So it's a really important area for economists to be looking when we evaluate new ways to treat depression, which is the context for this study. I'm part of the group called the PGX Project for short. It's about pharmacogenomic testing, which can help physicians guide their treatment decisions on which type of antidepressant drug is more likely to work for patients. The goal of the project overall is to ask what is the effectiveness and cost effectiveness of introducing pharmacogenomic testing in BC and as a routine component of clinical practice in the care of people with major depression. My piece on this project is the cost effectiveness analysis. So in cost effectiveness analysis, we weigh the costs and benefits, and we do this by comparing two competing alternatives. So for the decision to adopt the PGX or pharmacogenomic guided prescription strategy, we would compare that to the current standard of care, which is a trial and error based method of estimating how a patient will respond to an antidepressant. We look at the total costs for the new strategy and the total benefits for the new strategy compared to the current standard of care costs and benefits. We do this with a very detailed model, which I will direct you to a poster by Mary Bunka to learn more about that is at this conference. But very briefly, a patient will, when they seek care for major depression, they will enter the model and we can simulate all of the steps that they go through and all of the costs for each of these steps. In the case of major depression, you can have a pharmacogenomic test at one of these red circles, which will determine how you respond to different treatments as a result of the test and what changes after that decision is made. So when we look at the costs, we can look at it different ways. And the big deal here for this talk is that perspective matters. If we're thinking from the perspective of the healthcare payer, the cost of a pharmacogenomic test can be about $600 or $700, and then there's the physician service fees to order the test and to relay the information back to a patient who would like to receive treatment from the test. And then there's the cost of the prescription drugs and some hospitalization costs for people with major depression and that go down with successful treatment over time generally. And that's the healthcare payer's perspective. But the other perspective is the patient's perspective, or what I call the societal perspective. And these costs, as indicated in orange here, can be substantial. It's been estimated that they are almost twice as much as what the healthcare system's paying in major depression. And this is really a unique situation. So we needed to look at this quite thoroughly when we're doing the cost effectiveness analysis to help us make a more accurate conclusion about what this test can offer to us. So societal costs broadly are considered costs that are paid for medical treatment by patients and people in their support network. This includes productivity costs, such as loss of paid or unpaid work, informal caregiving that's required and people aren't paid to do, and out-of-pocket expenses like prescription drug copays, costs for counseling appointments, that sort of thing. And the idea is that if we can't can't see it, we can't measure it in the model. And we need to have some values that sort of estimate all of this information so that we can include that in our decision about the pharmacogenomic treatment. The way to estimate costs, it's quite tricky. There's not much known about it, and they're often invisible costs. The way that I've decided to approach this problem is to take a four-pronged approach. First, I worked with a stakeholder engagement group with my study team members, and then I developed a literature review and data extraction process to get some numbers to kind of come close to what we think is happening for patients, and to represent that as accurately as possible. And patients have been a part of each of these steps as we go along. We also have administrative data for the province that will give us direct data-driven estimates, and then we can correlate this with labor force participation data. So the stakeholder engagement meeting went in 2021. It involved patients and healthcare providers and decision makers. And before the meeting, we provided stakeholders with a handout about the types of societal costs we wanted to hear more about. And we had a really open discussion to get some guidance on how comprehensive we needed to be. The guidance resulted in us learning that we need to look over the long term for these costs, because depression affects a patient's ability to work, and it can last for years. There's lots of workplace stigmatism that patients face, and it impacts one's ability to advance in their career. So they're long-term effects. The committee also mentioned that there's major inequalities in access to psychotherapy services in BC. And a lot of patients just can't afford to receive that form of treatment, which is recommended. And some physicians will change what they prescribe just based on what patients can afford. Some of the out-of-pocket costs are very high compared to what people earn, far above the 10% threshold. We think in some cases the costs are too much and people give up. The implication for our analysis is that we have to be really comprehensive in this estimate. We don't want to underestimate what patients pay. So the next section is going to talk about the literature review and making sure that we get all three types of societal costs: the productivity impacts, the out-of-pocket expenses, and anything that indicates informal caregiving costs from the literature. So to do this, I included studies from primary and secondary published work that focused on major depressive disorder and that also reported societal costs in the methods that were paid, and they had to be paid by patients or support people or anyone outside of the medical system. We excluded mental illnesses that did not include MDD in the study or major depression, and any articles that were not primary or secondary articles and reviews and opinion pieces counted as that. And we also excluded studies that did not provide enough details for us to extract the cost data. The tool that I used to extract literature captured the context of each of these studies. It captured the grade of major depression because the model can simulate major depression outcomes based on mild, moderate, or severe major depression. And I looked at the grade of the method of grading major depression, because that can be quite different between the studies. And I captured the cost categories that were included, the evaluation approach used in the studies, and the currency and year the study was published, and translated that into weekly 2020 Canadian dollar cost for loading into the model as an input. Here's the summary of the search process. It was fairly simple. I just used the keywords societal costs and depression and got a decent amount of articles from a very common medical search engine, PubMed, and was able to retain 147 of these articles after screening by title and abstract, and sufficient enough to number to apply our data extraction tool and get some costs in the analysis. Most of them were included from the full text review. Of these studies that met the eligibility criteria, the majority were European, and There were, they are somewhat comparable to Canada's healthcare system. There were 10% of the studies that actually were from Canada and only 15 from the US, which would not be considered comparable to Canada's healthcare system. And the types of studies that I refer to were cost effectiveness analyses. Often the societal cost piece was added in to include that perspective. So it is an important issue for major depression, as other studies also include these data. But there are also some deliberate studies on productivity only and just costs only for major depression. The categories of societal costs were quite divergent, with the majority of the studies only reporting productivity costs. Only 9% of all the studies included all three categories. So we had to sort of aggregate the results from this literature review to convert that into cost inputs for the model. And this is what they look like. It's a fairly what we expected from the data. We have larger costs for severe depression because most people cannot work if they have severe depression. So that makes sense. And we can see there's a difference between remission of MDD when a successful treatment has been achieved, and the overall costs are a bit lower per person. So this is helpful. It gave us a starting point, and by no means is it perfect, but it gave us a place to start for including these as inputs in the model, and a place to go next with the third approach, which was to use administrative data. And we have just finished this analysis now. It's a little bit too soon to go into it, but by looking at the physician billing fee patterns across the province and hospital admissions, we can calculate how far patients have to travel to get to their clinic and think about what it costs them to drive, or some people have to fly to receive treatment. And also we have information about the costs of prescription drugs and the amount that is paid for by the pharmacare coverage, and that's what's passed on to patients. And we can divide this up by income quintiles to see the prescribing behaviors, how they change by income. So I'm very excited to show you this in the future. It will also correlate with our labor force participation analysis. But we're not there yet, and we have a lot to learn. We're still looking at something in the dark with a flashlight shining on what we see, but we have gotten a little bit closer, and I couldn't have done this without my network of collaborators on the study, including patients who are here today and have been absolutely wonderful help in sharing their lived experience and bringing this perspective to the analysis. So I'm very grateful to everybody, grateful for your time here today. Thank you.